All right. I think we're all in. Is that correct, Sierra?
Yep, I imagine a few more will trickle in, but for now, I think we're good.
Excellent. Thank you. All right. Welcome, everyone. Just give you a few more minutes to let everyone in. I might make it a less than a few more minutes. We'll see. See how that's happening. Just want to make sure we have enough time for our speaker today. Okay, I'm sure everyone can catch up with me. Um, and we'll have plenty of time for our speaker. All right, so welcome everyone, and thank you for coming to today's town hall organized by Unity Health Toronto's Vaccine Plus project at St. Michael's Hospital. My name is Vincenza Gruppuso, and I'm one of the research coordinators with Vaccine Plus, funded through the Public Health Agency of Canada. The project's goal is to share vaccine information, specifically COVID-19 and influenza vaccines, and provide supports that are online, ready to use, and open access around understanding vaccines and vaccine uptake to leaders and staff in Ontario's long-term care homes and retirement homes. Information on how you can sign up for the vaccine project and its Vaccine Champions course will be provided at the end of this town hall. We're proud to share with you that this is the third town hall offered by the project. Today's topic is Should to How, Practical Vaccine Championing in Long-Term Care with our speaker, Sophia Ikura from the Health Commons Solutions Lab. Now, before we get started with the proper introduction for Sophia, I want to offer a land acknowledgement. We acknowledge that the land on which we live, work, and operate on, Toronto, is part of the Dish with One Spoon Covenant territory and is the traditional and ancestral land of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Haudenosaunee, and the Wendat nations. I'd like to take this opportunity to commit to continuing to educate myself about the histories, treaties, and injustices that shape where we are today, and to support Indigenous-led initiatives. We invite you to reflect on your relationship to this land, Indigenous peoples, and broader understandings of reconciliation as it relates to health. One resource that I've found to be helpful to my learning is the website provided at the bottom of the slide, native-land.ca. This website provides an interactive map with detailed information about Indigenous land and its history. So thank you for joining me in this land acknowledgement as we move forward in today's session with a spirit of respect, learning, and collaboration. So now just a couple of quick housekeeping items. First, please note that the town hall will be recorded. Participants' video and audio are off by default, so you'll not appear in the recording. And again, we'll share information about how to access this recording and previous ones and other resources at the end of the town hall. Second, there will be a question and answer session at the end of town hall, which will not be recorded. You can type your question in the Q&A box, or you're more than welcome to raise your hand. So I'm pleased to introduce today's speaker, Sophia Ikura. Sophia is the founder and executive director of Health Commons, an organization advancing community-driven solutions to health inequities by bridging disciplines like epidemiology, service design, and public policy. She brings senior executive experience across government, Crown agencies, and the political sphere, including serving as a senior advisor to the Premier of Ontario and 3 health ministers. She has worked on a range of strategies, from building a provincial nursing workforce strategy that led to 12,000 new hires, to health system funding reform and the integration of population health management approaches into health system planning at the local and provincial levels. Sophia is focused on amplifying lived expertise to drive practical, equity-focused change. I'm now going to hand it off to Sophia.
Thanks, Vincenza, for that warm introduction. I'm excited to be here with folks, sharing a little bit about what we have learned at Health Commons Solutions Lab around what makes for really effective approaches to building uptake around vaccinations, keeping people safe in communities and in our institutions. And so I think the first thing that I wanted to share was just a little bit about what I'm drawing from as I'm going through this talk. And you might find that there are things that I'm saying that are controversial, and this is an invitation to you in the Q&A section to talk it out. But just to begin by sharing that Health Commons Solutions Lab has been in this space since the pandemic. Like many other labs, we've kind of leaned into what was happening during the pandemic to bridge with the efforts of everybody else to help address what we were seeing. And during that time, the lab worked very closely with first 17 communities, and that has now grown to 32 communities. But we started with communities that were the hardest hit during the pandemic, where the rates of COVID were the highest. And that put us in contact with a lot of people and a lot of workers across those communities. Over the last 5 years, as the provincial trainers for community health ambassadors and community health workers, the lab has run both training for ambassadors who are out having the conversations that many of you are having, but also a bi-weekly community of practice. And that puts us into regular contact with folks who are out talking to what is now hundreds of thousands of Ontarians over the course of this time about their health, about well-being, and what's important to them. So throughout this talk, I'm going to be drawing from what we have learned. I'm going to share some of the insights from our team, and then I welcome you into the conversation after that. I think I want to just begin by talking about where we are today, and recognizing that it's a new context and a new moment. We are looking to build vaccine confidence beyond COVID, and really trying to understand what will help us shift the needle on vaccines today in our institutions and in our communities. And I'm going to talk a little bit about what that looks like, which is trust, and access and follow through. And I think it's important to note that what we saw during the successive campaigns of the COVID vaccinations was initially very high participation rates, even in the hardest hit communities, even the most marginalized communities. But since then, each successive campaign saw a dropping off in participation, and now a troubling broader trend that's emerging, which is declining uptake on vaccination programs that people have known and participated in for many decades. And so what this tells us is that it's not about a single vaccine. It's about trust, and it is about fatigue, and it's also about whether or not prevention still feels supported in everyday practice. And this is especially critical in long-term care homes and in retirement homes, where we know the stakes are very high and the work is already heavy. So the first thing I want to do is just begin by reframing what the decline is actually telling us, and to try and get really precise about what we think is going wrong in our efforts and what we might do to change them. So just begin by talking about the fact that what we believe is changing is that we're not talking about new vaccines and we're not talking about new science, but this new context that I talked about. And that includes both the erosion of trust and also the experience of barriers and access. And so, many of these vaccines aren't new. We're talking about seasonal vaccination programs, and we know every year there's a fluctuation in the match between the effectiveness of the vaccine and the flu that we're seeing. That's not new. The science is not new, but the context within which people are making decisions is new. And in this space, we do see two problems, I think, of equal weight. One is that this trust erosion is happening in institutions, in public health, and in campaigns. And we see it at our lab, especially in those communities that have been marginalized by systems. And we recognize that even in my own team, we are talking to people from those communities, and they also make up many of our staff. And so there's a really visceral and honest and authentic connection to the experience of those who are living in marginalized communities, and facing a lot of the realities in front of them today. At the same time, and with equal weight, I often really reinforce that many people face very real logistical barriers. So in those spaces where there's overlap with the intention, but there's challenges in getting into to clinics or being able to get your vaccine, that intention doesn't end up turning into action. And so I want to talk about this question today around building confidence in vaccination programs or rebuilding confidence in vaccination programs, not as a single issue, but as an issue with multiple parts. I'm going to start first by talking about what we learned during the pandemic, but I think is something that has been true always, and that is that trust has either been earned or it's broken. And in both of those cases, it is very difficult to change where you are. And so we have seen across many communities that for them, skepticism isn't ignorance. In many cases, there is a sense that skepticism is protection. We know that history for many folks it matters. We know that experience shapes belief systems, that skepticism can feel rational and may be rational. And so this means that trust work isn't generic. Often when we do our training with community health workers, we begin by working with people to help build a trauma-informed experience or a trauma-informed practice. And that really means understanding that past experiences of racism, neglect, poor care, sometimes intentional harm, has really shaped how new interventions are received today. And often our experience is that in speaking with folks, resistance often reflects that experience, and it's not a lack of information. I'm going to talk about that a bit more. We pull from this quote often in our training from Resmaa Menakem, that trauma in a person decontextualized over time looks like personality. Trauma in a family decontextualized over time looks like family traits. But the trauma in people decontextualized over time can look like culture. And so when we think about the approach to addressing people's concerns and opening up real conversations, having an awareness of things that we often attribute to personality or family traits or to culture, means really beginning to understand what has shaped that, what context has shaped that set of beliefs, and what that means for today. And so we know that this experience often varies by population and that it requires really careful attention to what that conversation looks like. I was speaking with a public health expert the other day, and I talked about vaccine resistance, and he said, "Don't you mean hesitancy?" And I said, "Actually, I really don't. I think it's important in this moment to draw a line between what is often and traditionally been understood as hesitancy and resistance." And I've learned a lot from my team about this. They spend a lot of time out in community. Many of them have done a lot of community activation and community-based research. And they have shared with me this really important nuance between resistance and hesitancy. And they talk about the fact that hesitancy often assumes that what's needed is more information, and that maybe what's at the root of a person's decision is a lack of information or misunderstanding about the data, about the science of it. And what they've shared with me that's important to really wrap our heads around, and it's challenging because we always want to be working in an evidence-informed way, but that resistance for many people is often shaped by their belief system and their worldview about how to stay healthy and well. It's almost like it's been described to me as almost like a personalized health plan. And it's also shaped by negative things like past harm and mistrust of institutions and the feeling of being unseen or fear of consequences. But very much at the same time, it is shaped by people's own beliefs about how to stay healthy and well and what that looks like. And often in our intentions to ensure that the vaccination programs we're rolling out are successful, when we make assumptions that people are acting in an uninformed way, it can become a very alienating conversation, and people will walk away from that discussion. So it's important for us to think about how do we walk into these conversations and really think about opening up dialogue around what is shared and what is common, which is talking about health and wellness, what that means to the individual, and what that means to institutions, and how to keep everybody healthy and well. And that's a dialogue. It's not a one-off, and it's not a set of key messages. Hmm. So I think I talked a little bit about this gap that we see that emerges when there's both trust erosion and there's access barriers. And often what I have observed is you may encounter somebody who says, I want to, but I don't trust it, and it's hard for me to do. And so we know that when trust is fragile and access is hard, then follow through fails. And even people who may be highly motivated to get vaccinated may stall out. So we know that this is not a conversation about telling people to just be confident or to just decide. We really need to think about what a new delivery system is for our vaccination programs. And this is where I believe that the soft skills come in. So when I talk about soft skills, I'm talking about what I have observed works really well. We're not talking about being nicer. We're not talking about being more persuasive, and that's very important. Soft skills aren't just about a conversation. They're really about how healthcare practitioners, staff, our peers, and how institutions talk, how we listen, and how we respond. And responding in many cases means how we redesign our systems in response to what we're learning. So validating experience without removing barriers isn't enough. Removing barriers without addressing trust isn't enough either. And I want to talk about what this looks like in practice. I think it's important to begin with what we know about the biology of trust and decision making. So we know that our brains are hardwired for mistrust. Our brains are biologically organized to minimize danger and to maximize reward. And often with that equation, change can be perceived as a threat. We also know, and I've talked about this, that skepticism is sometimes a form of protection that has actually served certain communities really well. And we can't deny that, that is a reality for many people. So decision making is going to be tied to these historical experiences with our institutions. And as we move through the process of trying to build trust and really encourage people with the right information and the right conversations and decision making, we know that it's important to validate people's experiences. And we also know that authentic and empathetic validation are the building blocks of trust. We use this triangle really often. This is Frances Frey's work in the trust triangle. She has a great TED talk called Begin with Trust, if anybody's interested. But what she talks about is that there's no one part, there's no leading element to what is required in becoming trustworthy. She talks about the necessity for all three parts to be true at the same time. So in one corner, you see empathy, which is a very clear message to people that you believe about them, in them, and you care about them, and you care about their success. There is also this piece around authenticity, which is, are you speaking in an authentic way, and do people experience the real you in that conversation? And then there's this other equally important component, which is logic. Is your reasoning sound? And it is very important that that reasoning makes sense to people, and that it lands effectively. We learned during the pandemic, and I'm sure you saw this, that overly reductionist messages or over reassurance damages credibility, especially in communities that have learned to be cautious. But we also know that you can give people the science and all of the facts, and if they do not believe that you care about them, they won't be in conversation with you and they won't be hearing you. So what we often talk about is that it's important to say what we know, that to be honest about what we don't know, to listen really closely to what matters to people, and to respect that this is often a process for folks, that it will take time and it will take many conversations to move to a sense of confidence in the vaccine. I asked my team, who, to be honest, I think are the experts. I said I was lamenting today that it wasn't actually them here speaking to you about this, but I asked them to share with me some of their best advice around do's and don'ts when it comes to these communications around vaccinations. And so, first of all, they talked about definitely not talking about trust communication, but trustworthy communication. And then they led me through a couple of things that stand out for them, messages that they often repeat in trainings, and things that they have learned are true over time. So the first is just this piece around not alienating people by dismissing their belief system or what's important to them, but instead inviting them into a conversation about health and well-being, and always leaving space for individuals' frameworks for health and well-being that can be complementary to a vaccination program or other prevention programs rather than sitting in opposition. So my mother will often say, I prayed the whole way through that process or the procedure or that lab or my vaccination. And prayer is as important to her as the science of whatever she's whatever intervention she's receiving. And ensuring that we talk about these things in complementary ways because they are equally important to individuals' health and well-being is an important part, for my mother at least, of feeling seen and not being alienated by messages around what we believe the science bears out around and what it does not. The next piece that I want to talk about was just not assuming that the decision to not get vaccinated is a signal of lack of care, either for the individual or for residents. And what they did talk about was spending time to find out what people's concerns are, really working to help them articulate what that middle ground is, what do they want, what's important to them, and working towards a shared middle ground. What is the opportunity for addressing both the needs of the staff and the residents' well-being, and how can you get there in dialogue? Another bit of advice that they gave us was that sound judgment, and this is often related to the evidence base, is very important, but no one will hear you if they feel judged in the process. So the advice from folks was to lead with empathy, to be honest about what you know and don't know, because in part this really diminishes the power dynamic that can often be experienced with people who are talking to the scientific experts, to keep the conversation going, and to also recommend, and this is drawing from my nursing background, that the change process of moving from maybe to yes and then yes to action may take many touch points. And in each of those phases of the journey may also require different types of interventions. Sometimes it's going to be conversations or evidence or hearing from people what's important to them. And at other times, it's going to be about removing the real barriers that they're facing in order to be able to get vaccinated. And it's also critical, and this is something that I have learned since starting the lab a number of years ago, is that every opportunity to be in dialogue with communities and with people that have different worldviews and belief systems from my own is an opportunity to learn how the system can shape itself to be in response and in service to the people that we mean to be serving. I also want to talk about, because I think this is important, that we know that trust grows when action is easier. So equal in a way to the question of trust is the necessity for effective access. Even when people want to get vaccinated, we know that barriers can stop them. And barriers for many people look like time off work, transportation challenges, maybe language barriers, or being able to have a detailed and nuanced conversation in one's own language. Booking systems can be problematic. Mobility can be problematic. And the cognitive load of how am I going to take the time to really understand this are all elements of the things that we hear stop people from moving from the yes, I want to get it done to actually moving to action. So when these barriers are in place, they can create that gap that we talked about between intention and getting vaccinated. And we also have to be conscious of the fact that many of these barriers hit populations very differently. So as we plan our interventions and our strategies, we need to be thinking about segments of the population that might have more transportation barriers, whereas for others, it might be language. And as I said, trust grows when action is easy. And one of the things that I have learned at the lab is that many of the barriers are actually system decisions. So if we can really internalize as system planners, managers, and leaders that good logistics communicate care, we can really see that this is where leadership has leverage. It looks like, for many people, time off for side effects, flexible scheduling, supports for after vaccination when people may have questions about side effects, and also may just not be feeling well. These aren't individual choices. These are all organizational ones. They're ones that leaders can either act on to remove friction, and they're much more effective than any messaging campaign ever could be from what we've observed. So for many, we know that even just a follow-up call matters as much as the vaccine itself, and it builds the foundation for how people are going to feel about their experience getting vaccinated this year as we think about next year. And I think that just takes me to my last slide, and then we can open up a conversation and speak to any. I'd love to hear from folks here about what they've seen work really well in their own long-term care homes, or even in their own personal experiences. But I want to end on this particular note, which is that speaking from a very personal experience, one of the foundational lessons in my career came from a deputy minister of health named Ron Sapsford. He was, I think, there maybe 12 or 15 years ago. And he was actually the ADM for long-term care homes for a long time, as well as for hospitals. So lots of system experience. One of the things that he was working to build among the leadership of the public service and leaders in healthcare was this really important lesson that leadership in our healthcare system is actually about becoming the stewards of a trustworthy system. It's about building both trust and also access, and maintaining all those features of trust and access that allow for, over time, trust to be rebuilt, for people to know that it is a system that they can lean on and that they can count on. And so we need to recognize that in this moment and going forward, prevention is not a pattern. It's a pattern. It's not a campaign. One of the most important pitfalls that we want to avoid is believing that closing the vaccination gap that we are seeing around influenza, around some childhood immunizations, is not about having more clever or more persuasive campaigns. We learned during the pandemic that people are smart, they're taking in lots of information, and they're processing it in ways that requires us to do something very different. We need to embrace the idea that when trust is hard and when access is hard, routine prevention often collapses first. And that's why I think all of us are paying very close attention to what declining flu vaccinations actually mean. It's a signal to us that both trust and access have not been holding over time, and that it's going to take us some time to rebuild. I think it's important to acknowledge that maintenance of access, maintenance of ease of access, and support of staff, frontline workers, is the work that we are looking forward and looking at ahead, and for all of us. And so we know that trust needs care. We know that access needs upkeep, and we also need that change needs leadership that becomes stewards of trust and access. And I think if we can do these things and really lean into these things, we'll see success in our efforts to keep people healthy and well. And with that, I'm going to turn it over to Vincenzo.
Yeah, so the Q&A, just a few little things at the end here that we have. So we do have, as we mentioned earlier in the Zoom, in the chat, we had the links to the feedback form. So we were always interested in learning more about what we presented to you, how we can do better. What did you like? What did you not like about this? So your feedback is extremely important, extremely important for us. Finally, we also have, oops, I think I went a bit too far. If you are interested in becoming a vaccine champion, you can join our virtual 3-hour vaccine champions course. Take a picture of the QR code here, or you can use the link there to sign up for the course, learn more about the project. And it's not too late to join the course. It's open until January 19th. And then Finally, again, just the last slide that's showing you the town hall feedback survey, the vaccine champions. We will be sending out an email with a lot of this information, including a link to the Wellness Hub site where you can look at our resources, download them, what works for you, and of course, get a recording of this. Again, thank you very much for sharing this time with us and hope you have a great rest of day. Thank you.